And again, why we get excited about this, again, out here in Montana, for example, the next level 2 trauma center from where I'm at is 4 hours by car. When the weather is nicer than it is right now. I'm looking at some huge snowflakes coming down. And we often can't go by air depending on weather. There is one level 1 trauma center in the state of Montana. It's 8 hours by ground. And, from a clinician perspective, sometimes the right answer is to send that patient to another facility that's got a specialist. But it's a huge ask to send these people to another center for 8 hours away and then have the specialist look at the patient and say, yeah, you're one of the 144 patients in this study that just can go straight home. And then you've got to call.
So just in your experience, like a level 4 or a level 3, how common are like MRIs or CT or any of the other imagery that people depend so much on?
Yeah, that's a really good question. And I think that's going to tie into something that we're going to talk about here in the end. But so I think your question kind of ties into what tools do you have available to help make the decision on if you can care for this patient at your current role of care or if they need to go to St. elsewhere. Is that kind of where you're heading with that?
Yeah. I mean, if I was... let's just pretend that I actually went to school, and I was at a level 3 center. I didn't have an MRI, and I got a patient that's like on the edge, and I don't know why. With my other tools, I could easily see they're like, hey, send him off to, the trauma, the level 2 or the level 1, because if I'm wrong, this will become catastrophic. And that's going to be my butt at the M&M talk there. Versus, if I'm wrong in that I err on the patient is fine. They just need fluid or they need a whatever. If I'm wrong and the patient decompensates here, everybody's going to look to me like, why didn't you send them to surgery, which we don't have, right? So. Just in a overabundance of safety, like, hey, let's just send them out. I can't get the imagery to give myself the confidence that they're fine, so I send them off. I just don't know how common like MRIs or CT are. Like, how far down do they go?
Yeah, and so unfortunately, there's not a great rubric on what is required at the different levels of care from a American College of Surgeons perspective on diagnostic imaging. And certainly the CTs are getting farther and farther down the pipeline, but it's not even necessarily whether there's a CT in your level 4 trauma center, if you have that in your, it's more, do you have a CT tech to run it in the middle of the night, which is often not the case.
Okay.
But if you are lucky enough to go to the Advanced Trauma Life Support course, which I highly encourage you to go with your PA or battalion surgeon when they go, I really like their approach to a thought process, which is once you've got an idea that your patient can't be managed where you are, stop futzing around and just work on sending them somewhere else. And again, we actually had one of those reviewed this week in our morbidity and mortality report at my hospital, where a receiving center had just done a pelvic x-ray, and based only on that, they said, oh man, we got to ship this out to Alex's hospital. But instead, and so in answer to your question, what tools would you need in a role 4 to help make the decision on this patient? I would say the tool you need is you being a really good clinician and having managed a number of critically ill patients in the recent past in various levels of resourcing, whether that's in a high resource, high acuity hospital where you kind of understand, quote unquote, what right looks like based on some smarter people in the room, which is what I like.
I mean, you're 100%. I don't think it's a trick. It's just this is what the body does, right? Have you mastered your art enough that you can zoom out and look at the whole picture? Or are you busy looking at,